Assalamu alaikum and welcome to the series of lecture on the respiratory diseases. This include asthma, COPD and pneumonia. The material has been taken and adapted from Medical Diagnosis and Management by Inam Danish, Lippincott Illustrated Reviews Pharmacology and Clinical Pharmacy and Therapeutics by Roger Walker. I am Shoaib Mohammed, lecturer in the Department of Pharmaceutics, Faculty of Pharmacy, University of Sindh. In this lecture, we will be discussing about chronic obstructive pulmonary disease, that is in short called as COPD. This is the outline of the lecture that includes the introduction, stages of COPD, etiology, clinical features, and finally management of COPD. Chronic obstructive pulmonary disease is a chronic condition in which there is irreversible obstruction of the airflow, and this irreversible obstruction of the airflow is usually progressive. The symptoms of COPD include cough, excessive mucus production, chest tightness, breathlessness, difficulty in sleeping, and fatigue. Preferably, the chronic obstructive pulmonary disease can be treated by anticholinergics, selective beta-2 agonists, and corticosteroids. Depending upon the severity, the COPD has been divided into four stages. Number one is the mild COPD, number two is moderate COPD, number three is severe COPD, and number four is very severe COPD. The mild COPD is characterized by forced expiratory volume of greater than 80% but less than 100. The forced expiratory volume is the amount of the air expelled by the patient from the lungs. In the control of the mild COPD, short-acting bronchodilators on need basis can be given. In the moderate COPD, the forced expiratory volume is 50 to 80%. And for the control of the moderate COPD, regular treatment with one or more bronchodilators can be given. And in this situation, rehabilitation with the exercise, nutrition, counseling, and education can also be carried out. In severe COPD, the forced expiratory volume is about 30 to 50%. And in this situation, to control, inhaled corticosteroids on repeated basis with exacerbations can be given. In number 4, the very severe COPD, the forced expiratory volume is less than 30%, or the forced expiratory volume is less than 50% with chronic respiratory failure. For the management of the very severe COPD, long-term oxygen therapy in the case of chronic respiratory failure can be given. In certain situations, the surgical treatment of COPD can also be considered. From the causes that may develop COPD, tobacco smoking is one of the most important and dominant risk factor. The other noxious particles also contribute into the development of COPD. These may include chemical fumes, irritants, dust, and gases. The clinical features or symptoms of COPD, particularly in severe disease, depend upon the predominance of bronchitis, that is the inflammation of the bronchi, or emphysema, that is the damage of the air sacs in the lungs. The clinical features of COPD patients with chronic bronchitis may exhibit excessive mucus production, and there will also be degree of bronchospasm. This will result into wheezing and dyspnea. The patient will of course have less supply of the oxygen, and there will be hypercapnia, that is also known as the hypercarbia, which is the excessive amount of the carbon dioxide present into the blood. These type of the patients will have a productive cough, and they will be overweight and find physical exertion difficult due to the dyspnea. That means if they are doing any kind of the work, they will be difficulty be doing that because of the shortness of the breath. These type of the patients are also known as blue blotters because their lips and the tips of the fingers turn into blue color because of the shortness of the oxygen. The clinical features of COPD patients with emphysema are different as compared to the chronic bronchitis. The emphysema is basically the damage to the air sacs. In emphysema, a patient will experience increased shortness into the breath even when he is at rest. There is minimal cough to the patient, and their sputum is scanty, very thin, and also mucoid. The mucus may be present into the sputum of the patient with COPD and emphysema. The patients are relatively thin and have pursed lips. The position of the lips is relatively outward because they shape their lips in such a way so that they take more of the air inside the lungs. The patients with emphysema are also referred to as pink puffer because their skin color turns to pink because of this condition. As earlier discussed, the smoking is one of the major causes of the COPD. So, encouraging the smoke cessation will be very helpful in the management of COPD. In other cases, supplemental oxygen will be given into the patients who are facing hypoxia even at the resting situations. A combination of ipratropium bromide and sympathomimetic agents is advised in all patients with symptomatic COPD. In other situations, oral theophylline, oral corticosteroids, and in presence of any infection, antibiotics can also be prescribed. If the patient is having hypoxia even at the resting situation, the oxygen therapy can be given for 15 hours a day. The drugs that can be given include the ipratropium bromide, available into the market with the name of Eton, in the form of inhaler. 2 to 4 puffs 6 hourly can be given. Tablet theophylline, that is available into the market with the name of Theogard, can be given as 350 mg twice daily. The prednisolone, a corticosteroid, can also be administered in COPD in the dose of 5 mg. In presence of infection, the antibiotics like Augmentin 625 mg every 8 hourly can be given. Clarithromycin 250 to 500 mg every 12 hourly can also be prescribed, as well as cefaclor 500 mg every 8 hourly can also be prescribed. The vaccines are highly recommended in patients with COPD. The vaccines of influenza and pneumococcal vaccines should be prescribed to the patients because the infection with influenza and pneumococci can cause the acute exacerbations of COPD. Finally, we conclude our lecture with this video.
Understanding Chronic Obstructive Pulmonary Disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes, of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs, called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
This was all about COPD. Thank you very much for your time.